Welcome, everyone. My name is Kimberly Doris, and I'm the Executive Director and CEO of the Graves' Disease and Thyroid Foundation. Our webinar today is Ask the Docs. We'll have a full 90 minutes of Q&A featuring Dr. Terry Smith and Dr. Suzanne Freitag. Dr. Smith is the Frederick G.L. Huetwell Professor in Ophthalmology and Visual Sciences at the University of Michigan. He is an internationally known endocrinologist who has studied Graves' disease, its eye manifestations, and related autoimmune disease for over 30 years. Dr. Smith served as principal investigator for research into Tepezza, a new FDA-approved treatment option for thyroid eye disease, and he was issued patents covering the use of IGF-1 receptor inhibitors in the treatment of TED. Dr. Freitag is the director of the Ophthalmic Plastic Surgery Service and co-director of the Center for Thyroid Eye Disease and Orbital Surgery at Massachusetts Eye and Ear in Boston. Dr. Freitag also serves as Associate Professor of Ophthalmology at Harvard Medical School. And in recent years, Dr. Freitag has hosted a number of patient education events and support group meetings at Mass Eye and Ear, which were a fabulous resource for the local patient community. Hopefully one day events like that can be safely hosted again, but in the meantime, we're happy to have everyone together here on Zoom. Next slide, please. This webinar is being recorded, so hopefully by the end of the week, we'll have it posted on our website at gdatf.org. Over the next 90 minutes, we'll try to address as many of your questions as we can, but if you don't get your question answered today, please reach out to us and we'll try to help. You can visit our website at gdatf.org, email us at info@gdatf.org, or call toll-free within the USA and Canada at 877-643-3123. You can also find us on Twitter and Facebook at @GDATF, and you can visit us at onegravesvoice.com, which is a collaboration between the GDATF, Horizon Therapeutics, and Rare Life Solutions. The foundation does receive funding for our educational programming from Horizon Therapeutics, although we maintain complete independence with regard to all decisions on content. We'd like to thank Horizon Therapeutics and VOZ Advisors for the technical assist today. Next slide, please. I won't read all of these topics, but this is our roadmap for the next 90 minutes. You'll see this slide again after each grouping of questions so you can keep track of where we are. There will be some skipping around between different topics as we want to make sure that the questions that came up most often were covered early in the webinar. You can also use the Q&A button to ask questions during the event. And if we run out of time before we can address your question, I'll put up our contact information again at the end so that you can reach out and we'll try to help get you an answer. Next slide, please. So of course, COVID-19 is top of mind for many members in our community. So we'll start with a few questions on that topic. First, I would invite you to visit our website at gdatf.org for a listing of credible COVID-19 resources, some more general and some specific to thyroid patients. You'll also find a link to the Graves, TED, and COVID-19 webinar featuring Dr. Smith. And Dr. Don Kikawa from UC San Diego Shiley Eye Institute that we hosted last April. You'll also find a write-up of a presentation that Dr. Freitag did several years ago on deciphering scientific studies. That talk was specific to TED, but it has some excellent general information to help you sort through the onslaught of information on COVID-19. And just a quick note that you'll hear us use the acronym TED or TED for thyroid eye disease. So with that, our first questions is, are Graves' disease patients considered immunocompromised?
Kimberly, would you like me to take that?
Sure.
So I'm Terry Smith in Ann Arbor, and I just want to add to that lovely introduction by reminding those of you in the program that I am a paid consultant for Horizon Therapeutics and Immunovant, both now active in the TED Graves space. So with regard to the question at hand, I would consider patients with Graves' disease, if anything, to be hyperimmune. That is to say, they have evidence of, of a hypervigilance with regard to their immune function. Now, whether this impacts positively on how they might be susceptible to getting a virus like COVID-19 or any other infection for that matter is not yet known. But I would not consider those of you with Graves' disease to have any sort of immunocompromised state.
Okay, thank you. And the next question is kind of related, if we can go ahead and advance to that. Is there enhanced risk in general for autoimmune patients?
And again, I would I'd reiterate that there's no reason with our current level of understanding to think that patients with autoimmune diseases in general are any more susceptible to COVID-19 or to experiencing a poorer outcome of the infection. Now, there are individuals with autoimmunity, with autoimmune diseases, who are on powerful immunosuppressive agents, and those agents might pose some negative impact on COVID-19 and its severity. But each one of those and each situation would need to be considered separately.
Okay, thank you. And we'll take the last question. And this was specific to thyroidectomy. Should patients post-thyroidectomy be concerned? But I would also ask that same question of patients who are recovering from surgery for TED. So Dr. Smith or Dr. Freitag, do you have any sense of whether there's an extra risk for these patients who are just recovering from surgery?
I'll chime in first and then Suzanne. As far as we know, there's no additional risk whether an individual's post-operative with regard to either thyroidectomy or rehabilitative periocular surgeries. Suzanne?
Nothing else to add. Thanks, Terry.
Okay. We can move on to the next category now, which is Graves' disease treatment options. So our first question, and we'll throw these out to you, Dr. Smith. If I have hyperthyroidism due to Graves, what's the best treatment option for me?
A great question. And a lot of the decision making is a function of personal tastes and practice patterns of the doctor involved, or the wishes of the patient. In my office, the patient and I come to mutual agreement on which path to take. But there are three highly effective broad categories of treatment for hyperthyroidism: medication, radioactive iodine, ablation of the thyroid, and surgical ablation of the thyroid.
Okay, and a question that came in late today, but that we get a lot. If the root cause of Graves' disease is the immune system, why do we only have treatment options that target the thyroid, and specifically two of the three that you mentioned either remove or destroy the thyroid?
Another great question. We have only now begun to understand the underpinning autoimmunity, the actual molecular and cellular players that misbehave in diseases like Graves' disease. So out of, I would call it naivete, we over the last many decades have focused on what I consider to be one of the innocent bystanders of the disease, that is the thyroid gland. But this is all changing as we become more intelligent in our approach to not only Graves' disease, TED, but also other autoimmune diseases.
Okay, thank you. And the next question, how long will it take my thyroid levels to normalize? And perhaps that depends on the treatment option.
Yeah, so this is quite idiosyncratic. Some of my patients normalize on medication within a couple of weeks. Others, it takes longer. A lot of determining an individual's personal requirement in terms of methimazole or propylthiouracil dosage levels has to do with things that cannot be predicted a priori, and so in some patients it's done by trial, but we should be able to get patients euthyroid within a matter of a very few weeks. With regard to surgery and radioactivity, radioactivity takes a variable amount of time to become effective, and it's important for patients to be monitored very frequently, every 2 or 3 weeks, to make sure they don't become hypothyroid. Surgery to probably a shorter a window of time to reach a therapeutically sought after result.
Okay, thank you. And the next question, are there any long-term effects of RAI, and in particular, any increased risk of cancer?
So this really, the question concerning RAI and cancer has to be really, I would say, quantified in terms of the dosages we deliver to patients with thyroid cancer, which are much higher traditionally than those which we use to ablate the thyroid in Graves' disease. There are small but very real increased risks of not only cancers in the head and neck, but throughout the body, and in the dosages we give thyroid cancer patients. The risk with regard to Graves' disease and thyroid ablation with radioactive iodine is substantially less. If it occurs, it's very, very rare.
Okay, thank you. And the last question, are there any alternative treatments that have been shown to be both safe and effective? And let's talk about both Graves' disease and thyroid eye disease. Dr. Smith, I'll let you tackle Graves' disease and then toss it over to you, Dr. Freitag.
Sure. Unfortunately, the drugs we have in our armamentarium for hyperthyroidism haven't changed in several decades. Certainly, well before I entered the field back in 1840. I hope that with the research that's being conducted now, and apropos of the question from a few minutes ago, we will have the insight into retraining the immune system definitively, so that we don't have to do anything negative to the thyroid itself. But unfortunately, no alternatives exist today.
Okay, Dr. Freitag, what's your experience with TED?
Well, I agree that it's almost an oxymoron in the way the question is worded, because if it's been shown to be safe and effective, then I wouldn't consider it an alternative treatment. But people are always looking for non-traditional medicine treatments for things, and I think probably the best example that a lot of people have heard about was the article about using selenium. So it's a supplement, and there is an article suggesting that it's effective in mild thyroid eye disease to improve symptoms and quality of life. But there are some inherent errors in that study, and primarily that selenium levels in patients were not tested on the subjects in the study, and so we don't know if they were selenium deficient. I think that even though it showed some statistical significance, I think that the parameters that they examined were fairly soft, and I have not had any patients who felt like selenium really helped them. So there's always the search for things like this, but I always go back to the basics: regulate your thyroid, don't smoke, and do what we tell you with regard to making sure that you don't lose your vision. And as we'll be talking about now, we have many more palatable treatment options for patients, especially with thyroid eye disease, and so hopefully fewer patients will be risking their vision and their eyes on alternatives.
Okay, thank you. And just a quick note, having really been in the weeds in some online groups, particularly Facebook, the people that are pushing these so-called alternative treatments, a lot of times say, oh, well, they're risk-free. There's side effects with surgery or RAI or meds, but these are risk-free. But that's not the case, and perhaps the biggest risk is just that it won't work, and your disease will progress. And with Graves' disease, it can potentially progress to a point that's fatal if you're not getting proper treatment.
I would just add very quickly that some of the dietary supplements that have been bandied about as useful in either TED or hyperthyroidism can actually do harm. And before any of you who are thinking about taking these drugs, please check with your doctors and make sure that they won't have any negative impact on your health.
Okay, thank you. And we can move on to our next category, which is getting a TED diagnosis. And we'll throw these out to Dr. Freitag, and then Dr. Smith, you can chime in if you would like. The first question is, what are the specific signs and symptoms of TED?
Thank you, Kimberly. And let me also disclose before I say anything further, I am also a paid consultant from Horizon Pharma. So with regard to this question, signs and symptoms of thyroid eye disease, if you talk to my residents about the things that I say most often, I am quoted as saying, I've never met two thyroid eye disease patients who had the same signs and symptoms. There's a laundry list of things that can happen to eyes and the tissues around the eyes, but the checkoff boxes for each patient are different combinations, and then how those actually end up affecting the patient as far as how they feel and their quality of life are also extremely different. So starting from some of the milder signs and symptoms, dry eye is quite common, a little redness of the white of the eye, some intermittent eyelid swelling or retraction of the eyelids where the upper lids are elevated higher than we want them or the lower lids are lower than we want them. Some patients complain of double vision. Some patients complain of pain behind their eyes or pain with eye movements. Some patients complain of significant swelling and redness of the skin around the eyes. Some people complain about loss of vision, a dimming of the vision, snow on the television screen type of changes, or decrease in the color vision, so dimming of vision. And those are, of course, very worrisome signs.
Okay, and we can go ahead and queue up the next question, but I also want to touch on, so the terminology thyroid eye disease. You hear thyroid eye disease, TED, Graves' eye disease, Graves' ophthalmopathy, thyroid-associated orbitopathy. Why do we have so many names for this one condition?
And I would say that probably the variations in terminology grew out of colloquialisms. Um, and to this day, our European colleagues typically call the disease GO, or Graves' orbitopathy, as opposed to the terminology we use on this side of the puddle, thyroid-associated ophthalmopathy, TED. They're all describing or identifying the identical disease process. So don't be confused by the terminology.
Okay. So our next question is, how do you know if you're in the active or inactive phase of TED, and how long can you expect each phase to last? Dr. Freitag?
So we often see a very simple graph with a line extending upward and then plateauing. And this is called Rundle's curve. And this is a very basic concept of this disease, where we go through an active phase and then things level off. And it doesn't imply that things go back down to baseline to normal, but it means that things become inactive. So we say in very broad terms that the active phase is about 1 to 2 years, 18 months. But again, no two patients with thyroid eye disease are the same. And so everyone has a different period of activity. What are we looking for when we're examining patients to determine if there's disease activity? Well, the activity is inflammatory. So we're looking for signs of active inflammation on our exam. So inflammation is redness, swelling, pain. So if you have swollen and red eyelids, that would be a sign of disease activity. If the white part of your eye is swollen or the blood vessels are prominent, that would also be a sign of disease activity. I think of the pain in the eye sockets as also a sign of disease activity. And then how do we know if we're in the inactive phase? Well, time. I meet patients at one moment in time, and it isn't always possible to tell until I examine them multiple times and see if they're progressing, because some people don't have really overt signs of inflammatory redness and swelling, but yet things are progressing. Maybe their double vision is getting worse and worse. So even if they don't have obvious signs of inflammation, their disease is active or progressing. So it's partly talking to patients and seeing how they're feeling about the problems that they're having, and then examining them. I worry more about patients progressing if their antibody levels are high, or if their thyroid functions are their thyroid hormone levels are very unstable. Those would also be concerning for active. Now, that being said, I meet a lot of patients with mild thyroid eye disease who have symptoms like dry eye and upper eyelid retraction. And I think there's a subcategory of patients who are mild like that, who it just kind of pops overnight. People just sort of wake up and they have this change. And many of those patients don't progress beyond that. And so I think, again, everything is so variable and each person is different. But in general, the answer is 1 to 2 years of activity.
Okay, thank you. And we can go ahead and queue up the next 2 questions at the same time. If I have another autoimmune disease that potentially has eye involvement, how do I know if my eye issues are due to TED? And then also, how can you distinguish TED between other common eye issues like glaucoma or conjunctivitis? Dr. Freitag?
Sure. So the bottom line answer is you want to see a really good ophthalmologist, someone who knows a lot about thyroid eye disease, to help sort things out. For an ophthalmologist, this is all pretty straightforward, but certainly from a patient perspective, there can be some overlap. So myasthenia gravis is typical for when it affects the eyes for causing droopy eyelids and limited eye movements resulting in double vision. So a lot of people with myasthenia and thyroid disease both share the common problem of double vision. But one nice distinguisher from these is people with myasthenia usually have a very droopy or closed eyelid, and people with thyroid eye disease often will have a retracted or wide open eyelid. There's also other testing, blood testing, and other exam points that can be done to try to separate these. But we also need to mention that there is an overlap in patients who have myasthenia and thyroid eye disease. It's said up to 10% overlap in these diseases. So if I see a patient who has Graves' disease and many stigma of thyroid eye disease, but yet they end up with a droopy eyelid, I'm going to pursue a diagnosis of myasthenia in this patient as well. There are less classic findings for patients with lupus. Lupus is a vasculitis that can affect many different parts of the body. And people with lupus often have retina problems and other things that are quite different from thyroid eye disease. Again, conjunctivitis, going on to the next question. A lot of people with thyroid eye disease who are not yet diagnosed may get diagnosed with conjunctivitis, because conjunctivitis means the white part of the eye is bloodshot, the vessels are very prominent. And certainly people with thyroid eye disease can have that finding. And so we do see patients coming in with sort of a delayed diagnosis of their Graves' disease or delayed diagnosis of their thyroid eye disease because they are misdiagnosed with conjunctivitis. But to an experienced ophthalmologist who knows a lot about thyroid eye disease, this will not be as common.
Okay, thank you. So we can move on to the next category, which is diet and supplements. And the first question is there any research to show that a particular dietary approach is helpful in Graves and TED? So we hear about people going vegan, we hear about people doing paleo, we hear about the Mediterranean diet. Is there any research to back up any of these approaches, either for Graves or for TED? And I'll toss this out to both our presenters.
Yeah, so unfortunately, no stringent studies have looked at this particular issue. Many of my patients, many on their own volition, will choose to adhere to a Mediterranean diet or gluten-free celiac sort of a diet, but there's no hard data to support the benefit of any of these dietary excursions. I would say that, like any other discussion I'll have with my patients, a healthy diet will benefit long term all who choose to follow that adage, and I certainly encourage it.
Okay, Dr. Freitag, and any studies on TED and diet?
Not that I'm aware of, but certainly not any that have widespread credibility. But to add to Terry's comments, I certainly have a number of patients who are so desperate they'll try to change their lifestyles tremendously to make themselves better, and that's commendable. And so people will choose, now there are some diets that are touted as being anti-inflammatory. And so people latch on to that because this is an inflammatory or partly inflammatory condition. And of course, some people start to feel better after they go on these diets. And that's one of the things we have to consider with all treatments and all alternative treatments in thyroid eye disease, is it is a time-limited disease. And so patients may have thyroid eye disease for a year, they're really frustrated, they're really desperate, so they start these diets. And then just the normal course of thyroid eye disease, things start to plateau and get a little better. And then they give credit to the changes they've made in their lifestyle. And we don't really have hard evidence in these cases because it is a time-limited active phase.
Okay, thank you. And the next question. Are there any specific foods that should be avoided with either Graves or TED?
So with regard to the thyroid itself and those patients who still have their thyroids, the issue of iodine content in the diet can become important because iodine is the dietary substrate that thyroid hormones are made from. So some of the actions of the anti-thyroid medications we prescribe are acting in a counter-regulatory manner to the thyroid seeing an adequate supply of iodine in their diets. And so I always caution in patients who have yet to either undergo definitive therapy for hyperthyroidism, especially to avoid a diet that's iodine loaded, because it may be very difficult then to control their thyroid function.
Okay, Dr. Freitag, any specific foods with TED that should be avoided?
Well, a lot of this, when there's not hard scientific data, we learn a lot from talking to our patients, and I'm grateful to my patients for telling me these things, and I cry a lot. And I had a patient 15 to 18 years ago who was a very bright, very insightful young woman with Graves' disease, and she had very bad proptosis and severe disease. And she told me that she had been to a cocktail party in which there was a large platter of jumbo shrimp, and she had just gone hog wild and eaten a pile of shrimp, and her eyes were really a problem for a week or so afterwards, and she absolutely blamed the shrimp. And so I put it in the back of my mind, and I've heard a lot of patients tell me that they do notice some changes when they have large iodine loads, like shellfish would be one of the biggest issues. I had a patient recently who has thyroid eye disease, sort of moderate. She's a very insightful person. She had moved from the center of the country to Boston, and she and her family members were trying to really be healthy, and they get to Boston and they were eating seafood and shellfish every night, figuring giving up red meat and just eating all this nice East Coast seafood. And her thyroid eye disease was getting worse and worse, and she felt like she was in the time frame where things should be leveling off, and she was a non-smoker, and she was doing what her endocrinologist told her and thought she was trying to be so good, and things were just going downhill. And so we talked about iodine load in certain foods, and she changed her diet radically based on that. And again, could be coincidence, this is not scientific study, but she did end up doing better after she cut back on the iodine. So do you have to avoid a nice shrimp cocktail here and there? No, but I think that there is a noticeable connection for some patients, maybe not for all.
And do you hear from patients who are affected by sodium or perhaps by alcohol, noticing that the swelling gets worse?
I advise my patients about that. Alcohol is a mixed bag because alcohol is a diuretic, so I don't hear as much about that. But for my patients who are really suffering from swelling of their eyelids, it's often worse in the morning. Almost universally, people tell me it's worse in the morning. And it's because of gravity. At the end of the day, when we're upright all day, our ankles don't look so great. Mm-hmm. And when we get up in the morning, it's often our eyelids that are swollen. And so I encourage people to sleep on a few pillows and really think about what their lids look like after different salt content diets. So if you're eating, a salty fast food meal versus a salad that's low salt, if it makes a difference, then certainly you would want to avoid those salty foods. And it does matter for some patients.
And
Okay.
certainly the salt content is impactful with regard to the cardiovascular manifestations of Graves' disease. I certainly go over sodium restriction, especially in my older patients and those with particular fancy for salty foods.
Okay, thank you. And we can go ahead and load up both of the next questions at the same time. We touched on selenium earlier. So are there any other supplements that can potentially help with Graves and TED? And are there specifically any supplements to avoid?
Yeah, I again would admonish those of you listening to run any thoughts of supplements by your doctors to make sure that you're not going to do yourself any harm. But as Suzanne has already stated, there are no credible studies to back up a benefit associated with any dietary supplementation, with the proviso that individuals are not, for instance, vitamin depleted, where supplementation might be essential to maintaining proper metabolic balance. And I think this goes for TED as well as for the thyroid centric part of the disease.
Okay, Dr. Freitag?
I don't know if you have any other questions coming up about vitamin deficiency in this, but this is probably a reasonable time to mention it. So there has recently been a link between vitamin D deficiency and thyroid eye disease. And so just as Terry touched on, you know, we don't want to have people harm themselves with too much of any particular supplement, but it seems that a deficiency of vitamin D with regard to thyroid disease may be worth supplementing back up to normal levels, not just for the thyroid eye disease, but just for general health. I'm hoping as time goes by, we can find more links like this. People who live in northern latitudes with less sunshine in the winter are at higher risk for vitamin D deficiency. And I believe statistics still show that the incidence of Graves' disease is higher in these types of areas as well. And, you know, is this the answer to all of this? Not necessarily, but it's certainly an interesting finding and something that we should consider in our patients.
Okay. Are there any supplements specifically to avoid? So I'm guessing that if you're scrolling through your Facebook newsfeed and you see a sponsored ad for a so-called thyroid support supplement, you should probably keep on scrolling and avoid that, would be my guess.
I think that's great wisdom, Kimberly.
The supplement sector of our economy is worth several $1 billion, I believe, annually. So there's a huge financial incentive for people to sell supplements. And I'm sure there are a lot of people who sell them just for that purpose. I'm sure there's others who really truly believe in what they're selling and how it can help people, but there's just not science to prove it. But just remember, people make billions of dollars on supplements.
And they have the potential of doing harm.
Absolutely. Everything in moderation.
All right, thank you. So we'll go ahead and move on to the next category, which is Tepezza. And again, a reminder that the GDATF does receive funding from Horizon Therapeutics, but we do maintain complete independence in terms of editorial content. So we can go ahead and queue up that first question, and these I will toss out to both of our presenters, whoever would like to tackle these. The first question is, what is the window of opportunity between when you first receive your TED diagnosis and when Tepezza will be effective? And then a follow-up question, can it be used on inactive TED?
I guess I'll start with this. So the scientific answer to this is we don't know. This data has not been released to the public. I'm not going to say it doesn't exist because I don't know. But to my knowledge, there's no published data on this. From the practical perspective, so this drug was FDA approved at the end of January, and we have the clinical trials that led up to that point. But as far as just independent physicians, not part of clinical trials for this drug, we don't really have people who've completed the 24-week, which is 6-month course of this drug. Well, we're just getting to that point now. Basically, I don't have any patients who've completed their Tepezza, but I have some who are well into it. We don't know. So the clinical trials really focused on treating people with active thyroid eye disease. And so we know the data for that from the clinical trials that it is very effective in people with active thyroid eye disease for many of the problems they're having, ranging from reduction of proptosis, improvement of eye motility and double vision, reduction of lid swelling and edema. And in fact, it's improving things that I wasn't really expecting it to improve, like when people have puffiness of their lower eyelids, not from swelling, but just from fat hypertrophy. Even that is improving in my patients. So we're learning more and more as more patients ingest this who have thyroid eye disease. So I don't know that there's really any window of opportunity. Certainly, we like to treat people as early as possible that we know would benefit from treatment, because we can prevent them from getting worse and having all of these more advanced problems that we need to reverse. So I'd rather reverse minor disease, mild disease, rather than try to reverse severe disease. So certainly we want to get people on this medication or any treatment we're going to do for that matter as early as it's deemed that they would benefit from treatment. There's a risk-benefit ratio, cost-benefit ratio to things. And so once we think they're in that range of being in the beneficial category, then it's great to start treatment. Can it be used on inactive thyroid eye disease? There is not published data on that, but I can tell you it's a big buzz among physicians and people who deal with thyroid eye disease. The question for me is not really how soon can we start Tepezza in the process, but how late in the disease can we start it and still expect to see or hope to see effects. So I have some patients now who I would call plateaued. They're not actively progressing, who are probably not going to progress, but they're recent enough from the active phase that we are starting Tepezza. And so I think as all of us push the envelope in that direction, we're going to have a lot better idea on whether it works in inactive patients and how long inactive.
Okay, Dr. Smith, do you have anything to add?
Yes, just to embellish slightly what Suzanne has reviewed, the trials, both the first and second trial, restricted enrollment to individuals who were not only very active, but were very early, within 9 months of presentation of the ocular parts of the disease, that is TED. That was done to stack the cards, if you will, to favor what we all believed intuitively to be the most likely phase of the process to respond to a medical therapy. Having said that, the FDA approved the drug for TED without any stipulations of active versus inactive date from the time of presentation, any of that. Just the diagnosis of TED. Now those of us who toil in the land of the laboratory realize from our work that, number one, the disease is probably active on a molecular level for the rest of one's lifetime. And even though we can only detect clinical activity by examining the patient, we can't really define what I would view as the critical part of the decision making of active versus inactive. We don't have the molecular tools yet to test individuals and to help us guide our therapy. There are clues that this drug will be effective well beyond the 9-month time window that we used in the trials. And in fact, a paper out of UCSD, a single case report in the American Journal of Ophthalmology just came out a few weeks ago, reporting an individual who had gotten had first been diagnosed and symptomatic from Graves 3 years before they presented, and had developed eye bulging 2 years prior to them coming into the attention of the doctors who reported the case study. And the patient was started on Tepezza, and there was a dramatic reduction bilaterally, that is in both eyes, from quite severe and asymmetric TED. So that's just one case report, uncontrolled, but it, as we accumulate our knowledge of this disease and how it responds to Tepezza, this may in fact be a touchstone to how we think about this drug in the context of far longer lived TED.
Okay, thank you. And we can move on to the next question. What are the risks and potential side effects? And I'll let both of our presenters address that.
Terry, do you want to start off on this one?
Sure. So during the 2 trials, there were several mild to moderate side effects or adverse events that were noted. Among those that seemed clearly related to getting Tepezza and not placebo were changes in auditory function, so that some of our patients developed ringing of the ears, or a sensation similar to when one jumps off of a diving board into deep water and then comes up and there's a fullness of the ear. A couple of patients described it as kind of like I feel when I get off of a long plane ride. Um, and importantly, those events were self-limited. Um, some of the patients were actually evaluated audiologically and found to not have any particular disturbance, and they were transient, self-limited, and eventually went away. Muscle cramping was not uncommon. In fact, when Ray Douglas and I practiced together here at Michigan, um, and our first few patients in the trial, the initial trial, patients would come in, they say, you know, I feel great, except I've got cramping. Then we look at each other and we'd kind of smirk and we say, aha, we know, to ourselves, of course, we know who's getting the drug and who's not getting the drug.
Mhm.
So it wasn't uncommon, and it's my impression that among patients being treated post-trial, that this is not uncommon. Again, these are generally mild cramps, typically of the calf muscles. When they first came to light, we proactively checked a whole lot of laboratory tests that could have explained something going on metabolically, and found nothing. In fact, these symptoms went away. Importantly, to my knowledge, none of the patients receiving Tepezza discontinued the study on account of the cramping. Another side effect was some worsening in carbohydrate tolerance, seen particularly in patients who had already had a diagnosis of diabetes mellitus when they entered the study. Though a handful of individuals de novo developed carbohydrate intolerance, were what was probably unmasking of underlying carbohydrate intolerance while they were getting Tepezza. These were dealt with quite effectively by increasing as needed the diabetes medicine that patients were already receiving. And I think critically, the abnormalities that we saw, or the necessity for increasing diabetes medication, went back to pre-study requirements once patients had stopped receiving the Tepezza. And another important point, I think, is that there were no instances of ketoacidosis in diabetics receiving Tepezza. The bottom line here is that individuals who either have recognized diabetes or carbohydrate intolerance specifically should be monitored by their doctors for any worsening of their intolerance to carbs, and all individuals should have good baseline, and sometime early in the treatment phase get tested for their blood sugar levels and what we call a hemoglobin A1C level to make sure that they're not developing carbohydrate intolerance.
Okay. Dr. Freitag, are you aware of any additional risks or side effects?
Sure. So we avoid this in pregnancy and breastfeeding, and we test patients with each IV infusion they get to make sure that they're not pregnant. The drug should not be prescribed in people with inflammatory bowel disease like Crohn's disease or ulcerative colitis because of the risk of making it worse. Interestingly, the most common reported side effect, as Terry mentioned, was the muscle cramping. And I do ask my patients about that, and I have about a dozen patients or so on the drug currently, and none of them are really noticing any of that, which I think is quite interesting, being one of the most commonly reported side effects. What my patients are experiencing, most of them are doing great. Some of them tell me they feel like they're getting saltwater infusion, like no side effects at all. But some are getting a flu-like feeling for a couple of days, which in most of, well, only 2 of my patients have had that. Very, very mild, but just tired. Their stomach feels a little weird. They just feel a little unwell. I had one patient who felt that way for about a week, and she had more moderate symptoms. They're so enthusiastic to continue the drug because they're so happy with what it's doing for their eyes that they take it in stride. And time will tell as they get more and more doses of this if it's more common with the earlier doses and less common with the later doses. But that's the most significant thing that we're experiencing. So I'm warning my patients about that. I've had one patient that has a little ringing in her ears, but she has had it in the past. And so whether it's a coincidence or unmasking a little bit of that, but we are offering audiology baseline testing on all of our patients, so we can hopefully learn more about the side effects and why some of them happen.
Okay, thank you. And we'll take the next question. And I'd also like to bring forward a couple of questions that we had from the end. So is Tepezza effective for double vision? And then also we had some people ask if there was any effect on thyroid function from taking Tepezza, or if there was possibly any relief from the skin issues, pretibial myxedema, which can appear as a rash on the front of the shin.
So in answer to the double vision question, without a doubt, Tepezza is highly effective in improving double vision. We now think we understand why that should be. But a resounding yes. Double vision improves, as does eye bulging. The impact can be very, very rapid. I've had a patient whose double vision vanished within a week of receiving their first half-dose infusion of the drug. And so it seems that many, not just the eye bulging, but many of those surrogates we consider to be markers of not only disease activity, but disease severity, seem to improve substantially with the drug. Now, with regard to the second question, which is near and dear to my heart, because much of the basic science that we performed in my lab, the molecular stuff, the mumbo jumbo black magic that we performed was actually conducted not only in fibroblasts from around the eye, but also cultured thyroid cells from our patients with Graves' disease. And while we don't know whether Tepezza will obviate the need for thyroid medication directed at controlling hyperthyroidism of Graves' disease, there's reason to suspect that might in fact be the case. So you might ask, so why, you dummies, if you know you've gone through all the trouble of performing 2 clinical trials and you can't even answer that stupid question? And the reason is that when we designed the trial, we realized that any impact on thyroid function might make quite difficult our interpretation of the clinical response. That is to say, if the drug were improving thyroid function, was it that the drug was working through that mechanism, improving thyroid function, which in turn made the eye disease better? Or was it a direct effect of the drug on the TED itself? And so what we did was to require that all patients enrolled in the study were close to being normal or euthyroid with regard to their thyroid function. So the studies, both of them, were inadequately what we would call powered statistically to pick up any therapeutic benefit of the drug on controlling thyroid overactivity, or for that matter, underactivity, because 15–20% of my patients with Graves' disease and eye disease, TED, present not with hyperthyroidism, but with hypothyroidism. And they never develop hyperthyroidism in the course of their disease. So, great question. The jury remains out on that, but we're looking into that possibility, and certainly are as eager as the questioner as to the correct answer.
Okay, thank you. And we'll take the next question. Is Tepezza better than steroid therapy for TED?
Suzanne?
Well, the scientific answer is this has not been tested. Tepezza does do some things that steroid therapy generally doesn't do or isn't expected to do, the main thing being reduction of proptosis. So when the eye is bulging, we have to know what our expected outcomes are when we start a therapy. When I start steroid therapy in thyroid patients for thyroid eye disease, I expect their eyelid inflammation, redness, swelling to improve. It's maybe 50-50 at best on improving double vision. And there's a lot of things I don't expect to improve, like the proptosis, bulging of the eyes. So Tepezza, the main outcome measure for the phase 3 clinical trial was reduction of proptosis. So we know that Tepezza can do that. I'm finding in my experience, Tepezza is fixing things, as I mentioned, that I didn't expect it to do, like reduction of the puffy fat in the lower eyelids. I'm curious to see how it does with eyelid retraction. Certainly better in some of my patients so far, but that's a really common problem, to have an eyelid too high on the uppers or too low on the lowers. And certainly I'm seeing improvement in that, and steroid doesn't always do that either. So do we have any head-to-head studies comparing these two things? Not yet, but we know that Tepezza can fix things that steroid traditionally doesn't.
Okay, thank you. We'll move on to the next category, which is hypothyroidism. So we talked about RAI and surgery, and obviously you'll have permanent hypothyroidism if you undergo one of those 2 treatment options. But how common is it for a patient to flip from hyperthyroid to hypothyroid without having RAI or surgery?
So the short answer is it's pretty common. And I would liken it to a quote battle of the bands, unquote. So what underlies the abnormality in thyroid function in Graves' disease are antibodies directed against the thyrotropin or TSH receptor. And we know now that those antibodies can have very different consequences in terms of thyroid function. And there are so-called stimulatory antibodies which rev up the thyroid to make more and more thyroid hormone. And that's the basis for the hyperthyroidism of Graves' disease. Remember that normally a molecule called TSH or thyrotropin, which comes from the anterior pituitary, regulates thyroid function. And there's a feedback loop where thyroid hormone produced by the thyroid loops back and downregulates the synthesis and release of TSH from the pituitary. But in Graves' disease, there's no counter-regulatory loop. And so the immune system keeps pouring out these antibodies, and the hyperthyroidism and resulting thyrotoxicosis continue unabated unless we intervene with medical or surgical therapies. Now, besides these thyroid stimulatory antibodies, are antibodies that have the very opposite effect. They block the receptor on the thyroid cell and essentially paralyze the thyroid and make it less effective, less active in generating thyroid hormone. And under those circumstances, patients can develop hypothyroidism. So what often occurs in patients with Graves' disease is that for some period of time, one of those two broad categories of antibody directed against the thyrotropin receptor dominates. And depending upon which of the antibody types gets the upper hand, will then determine whether the patient is hyper or hypothyroid. And so some of my patients actually cycle with great frequency, so that they may be hyperthyroid for several months or a year, and then they'll come in out of the blue and they've become hypothyroid, and thus they represent a challenge for properly regulating their thyroid function. And some of those patients get as weary as their doctor in terms of how to manage them long term. And after a few cycles, they say, Terry, you know, let me make an appointment to the endocrine surgeon and get my thyroid out, or let me undergo radioactive iodine because I can't take this roller coaster ride. But anyway, that's the explanation for why individuals can flip from hyper to hypothyroidism.
Okay, thank you. We'll take the next question. Should I take brand name thyroid hormone replacement, or is generic okay? And then a follow-on to that, do you have any experience with the liquid version of thyroid hormone replacement?
Yes, yes, and yes.
Okay.
So when I was a young guy and training, um, back in the 70s and 80s, the level of bioavailability of drug was somewhat variable among the unbranded thyroid hormone products available. And so we used to counsel our patients that if they could afford it, or if their insurance companies would allow it, they should take branded Synthroid, because lot to lot, it was our experience that there was much less variation uh, in what the patient got when he or she took a tablet of Synthroid than taking generics, which seem to vary not only lot to lot, but also with regard to changes in manufacturer. And many drugstores would buy whatever was cheapest in the marketplace, and so patients would get one brand X one time, and then a brand Y the next time. And many of my self-aware patients were quite in touch with these variations because of the impact. Now, drift ahead to 2020, and the generics are probably just about as good, and maybe as good as the branded Synthroid. Some of my patients are on Tirosint or Tirosint SOL. I've had good experiences with all of the above. I think a lot of it has to do with the purchasing power of the pharmacy that you send your prescriptions to, whether you get consistency in terms of the manufacture of the unbranded drugs, which are considerably less costly than are the branded ones. But if all things being equal, if you're satisfied with how you feel, and there's good consistency between prescriptions, I would stick with what works.
Okay, thank you. And the last question in this section, can you talk about T4 to T3 conversion issues? Are there specific patients for whom this is a problem?
There are rare patients in whom T4 to T3 conversion kinetics and profiles seem to differ from most of us. And there are patients who have been in my practice, and I'm well aware of patients seeing other practitioners in whom at least the patient herself or himself really believes that this is an important consideration, and that they in fact need to take a T3 containing agent along with levothyroxine. And it's been my experience that taking T3 for simply replacing thyroid hormone need generally meets with dissatisfaction of the patient, because T3 or triiodothyronine is a very short-acting derivative of T4, and because it can, in some patients, lead to spurts of effect early in the day, and then diminution of whatever the feelings are associated with the very short-acting T3, so that they seem to have a biphasic sort of experience throughout the day. T3 ingestion as a replacement can also lead to a lot of symptoms such as palpitations, which are particularly uncomfortable to many of my patients. So I generally steer well away from prescribing T3 in this particular context.
Okay, thank you. And we can go ahead and move ahead to the next category, which is anti-thyroid medications. Are there any new anti-thyroid drugs on the horizon? We've got methimazole, brand name Tepezza, PTU. Is there any research being done in this area?
Not directly, but as I've suggested earlier, there are concerted efforts, not only in my laboratory, but in others around the world, to better understand and develop a more physiologic approach to taming the hyperthyroid gland, such as by what we would call re-education of the immune system, which ultimately I think will be the case, not only in terms of treating Graves' disease, both the TED and the thyroid overactivity part of the disease, but also other autoimmune diseases.
Okay, thank you. And if we can just go ahead and put those next three questions up, we'll try to, we're getting close to the bottom of the hour. Can you talk just quickly about the likelihood of remission with anti-thyroid drugs, and if we know who has the best chance to go into remission?
Sure. So the young are much more likely to go into sustained remission following anti-thyroid medication course, and those who have a relatively modest thyroid gland, that is, don't have a huge goiter, and there are those in our field who think that those individuals who have particularly high T3 to T4 ratios may in fact have less of a likely sustained remission following drugs like methimazole. Should the thyroid stimulating antibodies drop down to becoming undetectable during the anti-thyroid medication course, that also is a good sign with regard to likelihood of sustained remission.
Okay. Are there any specific triggers that make people come out of remission? Do we understand why that happens?
We don't, but I would say that it's likely that the same sorts of stress events that caused or triggered the initial episode of hyperthyroidism would likely have some play here. But no, we've not identified either a specific or set of specific insults that are the culminating factors in developing Graves' disease.
Okay. And then before we move off of this slide, do you have patients that are using methimazole on a long-term basis?
I do, and it reflects the change in my thinking over the course of my career. When I trained many years ago, the wisdom was to start patients on antithyroid medication. In those days, PTU was far more popular than methimazole, but it's the same consideration for the two drugs. That would just be a temporizing strategy, and after a year or 2 years, the patient would almost reflexively be discontinued from the drug, and if relapse occurred, then it was almost axiomatic that we would send the patient either for radioactive iodine or surgical ablation. But now that there's more and more accumulating evidence that in many patients tolerating methimazole is very common over the long term, and especially consideration of where the patient is along life's highway. If in older patients who have comorbidities and in whom radioactive iodine might pose a particular risk, such as developing or worsening of TED, or surgical issues in patients who have, for instance, heart disease or vascular disease, and who are at increased risk for general anesthesia. I feel very comfortable in monitoring my patients long-term now on methimazole, but with interval assessment of their laboratory tests and seeing them in the clinic and making certain that they're doing well on the methimazole.
Okay, thank you. And we can go ahead and skip to the next category, Graves' disease in children. And let's go ahead and bring all of those questions up since we're getting close to the bottom of the hour. And I'll just throw out to Dr. Smith first. Is there anything specific about the course of the disease in children that changes our treatment calculation?
As I just stated, they're more likely as a group to experience long-term remissions off of thyroid medications. So typically, I'll start them off on an anti-thyroid medication and watch them. Because I don't think that we as a scientific community have any sense of the lower limits of radioactive iodine dosing for the subsequent development of cancer. I'm much less likely to go down the radioactive iodine ablation route in young patients. That a lot of that just has to do with the fact that I'm quite conservative with regard to introducing that as any possibility in a young patient. And a lot of my colleagues, I think, would be in agreement. Others might cite the fact that there are really no convincing data suggesting that in the dosages that we give for Graves' disease that there's any real increased risk for developing cancers.
Okay, Dr. Freitag, do you see children that have thyroid eye disease?
Yes, we do. It's not common, but Graves' disease is not terribly common in children either. But it's a very different type of thyroid eye disease in young children, teenagers, and even people into their early 20s. Proptosis is very common and eyelid retraction is very common, but we can almost universally say they just don't get double vision. And when we do imaging, which we occasionally do, we see that the extraocular muscles are very thin. And so it's the more of the fat hypertrophy variant that we're seeing. If we could figure out why this is the case, it might help us to unravel this whole mystery of thyroid eye disease to begin with. So it's very interesting, but we are fortunately not dealing with double vision for the most part in these young patients.
Okay, thank you. And we can move on to the next section and go ahead and bring up all of those questions. They're related to orbital decompression surgery and strabismus surgery. So Dr. Freitag, I'll give you the floor till the bottom of the hour to talk about orbital decompression and strabismus surgery.
Sure. So orbital decompression is a surgery where we remove some of the thinnest bones in the inner side of the eye socket and the floor of the eye socket. We can also drill out some of the thicker bones in the lateral part of the eye socket, and with the goal of expanding the bony space and allowing the eye and the contents of the eye socket to settle backwards so that a bulging eye will move back into the head. And it's a great surgery. The inner wall and the floor can be done through the nose endoscopically. So for patients, it's not really much more traumatic than having endoscopic sinus surgery, which is a common surgery that I think most people understand is a fairly straightforward recovery. But the downside of doing orbital decompression, and it's a big downside, is there's a real risk of double vision after orbital decompression surgery. And that is because the whole contents of the eye socket shift. Because when we take out the medial wall and the floor especially, the contents shift nasally and downward. And anytime the eye and the eye muscles shift, they may not work as well as they did before. And even if they're not working well, as long as they move the same way as the other side, you don't have double vision. It's when the eyes are moving not completely together that we get the double vision. So we have run our numbers on this, and there's a lot of existing scientific data. And the risk of double vision is up to 25%. Some occasionally report higher than that after orbital decompression. Now, we do certain things during the surgery to try to prevent double vision, like leaving a strut of bone present to support between the floor and the inner wall of the eye socket. We can also leave a strip of the soft tissue present over the inner muscle of the 6 muscles that moves the eye to try to keep things from moving too far as things expand when the bones are down. But it's a real problem, and double vision is just very debilitating. And so what do we do about double vision? Well, there are surgical procedures that can readjust the eye muscles and how they attach to the eyeball, which are very effective in improving double vision. Now, if someone has very severe problems with double vision, it may not be possible to get it back so that you don't have double vision every single direction you look, up, down, left, right. So for people with very severe problems, the goal of double vision surgery to maybe have it so you're not double straight ahead and in down gaze, because those are the most important directions we look. But the other downside, if you have a decompression and get double vision, is it's probably going to be 6 to 12 months before you're a candidate for the double vision surgery, because things have to settle and heal. And the double vision surgeon will want to take multiple sets of measurements to ensure that nothing is changing. And once things are stable with regard to the eye movements and the double vision, then surgery can be contemplated. So even if you get a little bit of double vision, it's probably going to be 9 months before it can be dealt with. And that's a really debilitating problem. I'm just looking at the other questions here. So double vision risk, we talked about. So sometimes people have a little bit of double vision after decompression surgery just from swelling, and that'll improve on its own, but there's a real risk. There are alternatives to surgery in a few patients with double vision after decompression, including prism glasses. However, this is less effective for the type of double vision people get due to thyroid disease than for, say, a child that has an eye that turns in or out.
Okay. All right, we can go ahead and skip to the end slide. We have packed a lot of information into the last 90 minutes. We unfortunately just scratched the surface of all of the questions that we received. So again, please do reach out to us if we weren't able to get to your question today, and we'll help if we can. Many thanks to our presenters, Dr. Terry Smith and Dr. Suzanne Freitag, both of whom volunteered their time today. Thanks also to Horizon Therapeutics and VAZ Advisors for the technical assist. And thanks to you for sharing a part of your journey with us. So please stay safe and enjoy the rest of your day. Thank you.